Welcome to the Interventional Glaucoma podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. In this episode, the first part of our special two-part series, our four guests will discuss their quick learning curve, tips and tricks on getting started, how to explain the procedure to patients, the role of gonioscopy, viscoelastics and shot placement. In addition, they will also discuss their post-op results and patient care. Let's get started.
Welcome everybody to the 13th episode of the Interventional Glaucoma podcast, brought to you by Elios. Today we're going to talk about what I've learned from my first 100 cases. We are joined by a star-studded lineup of guests. We have Dr. Nils Loewen from Germany, Dr. Anselm Juenemann from Germany, Dr. Jose Belda from Spain, and my good friend, Professor Dan Lindfield from the UK. Between us, we have over 500 cases of Elios under our belt, and we will share our experience and some tips and pearls along the way. As early adopters to Elios, have you found it to be something that was quite easy to initiate in your practice? Maybe if I start with you, Nils.
Yes, I did. And actually, I've done about 300 tips from the first 100 Elioses. I would say, actually, you only need 5. That's 5 to get good at and safe in the eye. To me, that's all it took. And I've now trained fellows, and they too seem to need around 5 cases or so. Not all of them are trained with trabectome surgery or Kahoot blade. So really, I think it needs 5 to to get good at. Far less than I thought. To me, the biggest surprise was so first off, to me, it seemed to be as easy to learn as a trabectome, but also as awkward as it is to learn trabectome. Using a gonio lens, putting it on the eye, visualizing the angle. That's the only new thing for anterior segment surgeons who haven't done that. But once you're comfortable with that, you're good to go. And to me, the biggest surprise, I've done about 3,000 or 4,000 trabectome surgeries, is that you don't get any hyphema, thankfully, so our patients are much happier. And you don't get any synechiae. And that was the biggest surprise. I thought if you have 10 little laser holes, there are also some thermic effects, but I don't see any iris sticking anywhere. And that was a big difference to our trabectome cases.
That's brilliant. Thank you. And I think we'll come on touch upon a little bit about the post-op management and what we're seeing. But Jose, your first 5 cases, what were you how did you pick those first 5 cases?
I really didn't make a special pickup of the cases, because as long as we were already doing a gonio surgery, it was a standard gonio procedure. I think that the main point is that if you are used to work in the angle, that means that probably this procedure is going to be very easy to you. But if you're not used to work in the angle, you need to select the cases. And in my opinion, if you're going to start with a good case for Elios, you have to look for a patient that has a very shallow chamber. It has to be not a very deep set eyes, because if the setting of the eyes is very deep, it's going to be a bit difficult. And you have to practice before doing any kind of gonio surgery. Maybe in any patient that you're going to do cataract surgery, try to put the gonio lens, have a look at the angle, and maybe practice in the area. If you do that in advance, that will make things easier for you when you're doing the real surgery. But in my opinion, look for a big eye, not a very deep set eye, and also a nice angle in which you can see the structures, the trabeculum. If it's a pigmented one, it's much better, because you will see it much better.
Visualization is clear. Just to touch on a point that you made there, Jose, when you say shallow anterior chambers, do you mean that you don't want eyes that have a very deep anterior chamber?
That's what I meant.
And some similar question to you, when you did your first 5-10 cases, were there any pre-op characteristics that you were looking for that Jose had touched upon? Were there things that you wanted to avoid, shall we say?
So I do not care about the really deep anterior chamber, but the important point is that you can visualize the anterior chamber angle. That means you need at least chamfer 3 and 4. And if you start with angle surgery, because we have to separate or the differentiate between people who start with any kind of angle surgery or who are experienced with angle surgery would like to start with Elios, So these are really two different stories. The only important aspect, I guess, in Elios surgery is that the fiber is elastic and you get a bending. This is a bit different for all the other procedures, like Nils mentioned for trabectome or Kahook or Icent or Hydrus, whatever you do. And this is the only point you have to keep in mind because you have to select the right gonio prism, and it's important that the gonio prism does not interact with the fiber at the side of the paracentesis, because otherwise you get a jumping of the fiber. I guess it's a good idea to start with Elios, because just if one or two or three effects are not really in place with the trabecular meshwork, it's not really of importance, So
Yeah, I think you make a good point. I remember my first case, the probe does have a certain malleability, doesn't it? If you were to push too firmly on the trabecular meshwork, there is a bit of a
it might
bend
switch,
within that. And there is a bit of a risk that you may end up putting that shot a little bit too low. And I think talking about low, and I know Dan is an expert on this, and we've done a lot of webinars in the UK, and Dan's got some novel ways of doing his Elios procedure. Dan, do you want to sort of talk us through your Elios wide and your thinking behind that? Because it's a great technique.
Yeah, thanks, Gok. So I classically sit at the side and operate temporally, and then used to put all 10 shots in the nasal angle. But I felt it quite tight. You certainly get 8 in quite happily, but the 9th and the 10th, you're sort of almost looking for a space. So I thought, let's try and spread these shots out. And when you look at the cadaveric work, most of the collector channels are infranasal. So if you actually spin around and you do 5 shots from the side to the nasal angle and then sit at the top and going through a superior incision looking inferiorly, you can do 5 more inferiorly, and you can pretty much cover 180 degrees plus of meshwork. And it feels more in keeping with the laser because you get some nice laser holes and a definitive gap between them without them all being on top of each other. So I really like that. We're looking at our data. It's looking promisingly different. I'm not saying we're statistically significant yet, but we're certainly seeing a slight difference there in our data. And it seems to be more reproducible. So yeah, time will tell if it actually makes a difference or it's just an extra 90 seconds of faff for no reason. But I like the idea of moving around.
Yeah, it's true. I think when you've done your 10 shots all in that nasal quadrant, you do feel, particularly with the cavitation bubble that's created, that, hang on a minute, have I put those shots too close together? Whereas if you're doing it over 180 degrees rather than 110 degrees or something, you've got that much, that larger spacing. Just talk me through that superior incision, Dan. Do you have to enlarge a sort of side port for your IA, or does it go through
size incision? But a bimanual IA user, and my side ports they're a 1.0 millimeter keratome. There's the same 3-step like a main phaco incision, and it goes through 1.0. It's tight, it's really tight. So probably 1.2 would be safer and easier. You've already mentioned it, Anselm, about the torquing through the wound. So they sort of torque with a QU, not with a K. But if you get any sort of bending of that tip to reach the edges, as you start to shoot the laser and you ablate the tissue behind the tip, the laser kind of starts to go down or starts to go sideways.
Yeah.
And that's why if you shoot opposite yourself, you don't have to worry about this kind of warpage and torque too much. So actually, I like the two steps, the two incisions, because you're much more sort of neutral and straight across the anterior chamber rather than bending around the corner. It seems to limit that.
Nils, obviously, all of us have done a lot of cases now. Have you sort of got some sort of, have you sort of audited or looked at your results? What are you sort of seeing in terms of pressure reduction?
Well, I was actually initially quite pessimistic because I thought, why would 10 little holes be any better than a large 180 or 120 ablation as you can achieve with the trabectome, with a Kahook, and so on and so forth? That didn't seem to make sense that I would even try, but I did because It's a nice device. You don't get much hyphema. So looking at the data, we matched 200 patients of our 300 cases with EOT or with Elios to trabectome patients, and we used coarsened exact matching, which means that you're trying to find very similar pairs. It's of course not a randomized controlled trial, but you have a very balanced comparison. And lo and behold, the average runs about 1.7 millimeter lower with EOT. I was very much taken aback by that. And not only that, apparently the survival of the results is better. Now, I cannot talk from based on my own results. We've had 1 year follow-up, or a little bit more than that. But Mark Tuteberg, a friend of mine who moved from Zurich to, I think he's in Iowa now, he said he has a study as the senior author showing that actually the results are longer lasting than trabectome. So how could that be? Looking at our tissue culture models, we think it is these hinges that are covering the collector channels that are still suspended in the trabecular meshwork, so they're kept open. And if you just ablate or rupture the trabecular meshwork over a large circumference, then you don't have any suspension that keeps these little valves open. So that could explain why the results are similar in terms of pressure reduction, but why the effect might be longer lasting. So it's actually slightly better. It's not statistically significantly better in our case, but it's pretty close.
So Jose, so similar question to yourself. What are you sort of seeing in terms of pressure reduction for your patients?
What I've seen is that pressure reduction that we obtain with this procedure is a bit better than what we were used to obtain in the past with other procedures like a hook or eye stent. And I think that it's because you have better chances to achieve, let's say, a collector channel when we do 10 little channels in the trabecular meshwork instead of 2, which is what we obtain with eye stent, for example. Or as Nils said, I think that there is a pump effect of the trabeculum if it is preserved. I mean, if you just remove it with the cahook, probably this pumping effect is going to disappear after doing this type of surgery. So in my opinion, I think that this surgery could be I don't think that it's going to reduce much more the pressure than other angular surgeries, but in terms of the time that it's going to last, probably could be a bit better.
Yeah, good point. I think the atraumatic nature and mechanism is definitely really key. Dan, what are your views?
Yeah, I really like that pump theory, and I'm a massive fan of that. And it was the weekend actually. I was with my kids with our wood burning stove, log burning fire, and this sort of was like perfectly illustrated. If you light the fire and shut the door, i.e., leave meshwork intact, it burns slowly. If you open the door really, really wide, it burns better, but it's not perfect. If you leave the door just a tiny bit ajar or let the right amount of oxygen in, you get that lovely whoosh and the fire takes off. And it's the same idea with Elios. I think it's letting aqueous penetrate in a natural way, whereas ripping the roof off all the way around loses that. And I think it's that sort of valve, that pump effect that you've talked about, Jose. I think that's really key.
So one pearl I want to suggest for beginners to be very careful with is phakic eyes. It's actually a very good and safe procedure for phakic eyes, but you have to be careful with the viscoelastic you're choosing. You have to use Lurone. That's what you would use for ICS. It's not cataract. It must be based on methylcellulose. If you're using something that my colleague did, which was Discovisc, it has such an osmotic draw. The moment you're done with the procedure and you're aspirating out the viscoelastic, boom, the lens turns cloudy.
Great points, yeah. How do you sort of explain the procedure to the patients particularly patients that may have known about a device surgery and now you're doing a surgery without a device. Do you have any, Niles, do you have any sort of pearls of how you would explain how it works to the patient?
Well, I like to compare this to the strainer in the kitchen sink. People are familiar with the concept of that obstructing. Of course, we know in glaucoma there's no true particulate obstruction. It's a failure of the trabecular meshwork barrier as such. And yes, they ingest particles and so on and so forth. But basically, that strainer is not permeable anymore. And I say that, these little holes that you might have in your strainer, we sort of recreate them, but they're a little bigger, and so it does flow. But then I also caution them that while this works well and it's a first small step in this direction, we can combine it with cataract surgery so you function better. There's a chance that the drainage pipe underneath the sink might be obstructed. And so we're aware of this risk, but it's worth trying because of a chance of 80-90% of that actually working alone. And if we notice that there's no good pressure reduction, we will have to take it a step further and replace that drainage pipe, for instance, using a PreserFlow. That's sort of my spiel on that.
Yeah, good point. Jose, I'll give a scenario to you. You've got a patient, and they say, well, these channels that you're talking about creating, they may scar up. If I've got a little device in my eye, I know it's going to be held open by a device. How have you tackled those kind of conversations in the pre-op assessment?
That's a very good question. I normally use the magic word laser, which is for the patient is very, very. The patient likes normally he likes laser, and if we compare the laser that we're using in this glaucoma, which is a excimer laser that has been used for refractive surgery for years, and you explain the patient that normally we've been doing refractive surgery for patients and it's going to last for years because we shape the cornea, and you explain that we can also shape the trabeculum and open tiny holes or channels that will remain there probably for a long time, as the same we're obtaining when we shape or reshape the cornea with excimer laser. So probably for me, this is the way I can explain the patient that this is a nice technology that is going to last for a long time.
Yeah, very nice analogy. So a question to Dan and Anselm at the same sort of time. Have you had any cases that stuck in your head? Obviously, you've done over 100 cases each now that have stuck in your head saying, wow, that patient has just done so well. And then you've gone back and thought, was there something about that patient, whether it was a high pre-op IOP or a certain level of disease or type of glaucoma? Maybe I'll go to you, Dan, first of all, and some ponders that. Have you had any sort of spectacular results and any characteristics that may guide you towards these sort of mega successes?
Yeah, it's the kind of holy grail question, isn't it? I wish we all could do that pre-op. And Nils mentioned that there's patients with damaged distal outflow, which we wish we could spot, but we can't. So some of it is trial and error or a bit of luck. But yeah, we've all had those super responder patients we've talked about before, where you just get this amazing response that almost takes you off out of breath, really. I think it depends on how you measure it. So you're right, the ones with the highest intraocular IOP pre-op will come down more. There's that regression to the mean. So an outcome of 15 or 16 is about as good as you're going to get. And obviously, if you start at 18, it won't come down that low. But there are very few patients who start with pressures of 35, 40 because they're always on medication beforehand. As part of the clinical trial we're doing, we're washing patients out, and actually they're often in the low 30s pre-op. And actually, we're starting to see the real power of the device, or all devices, when you wash out patients first. But yeah, I wish there was a way of knowing. What I do really like about Elios is sort of the confidence and the reproducibility or reliability it gives me. I'm seeing that I'm getting a good response, maybe not always an amazing response, but a good response in a lot more patients. I can be more confident that I'm going to achieve that than I have done before.
Yeah, I think so. When we treat hundreds and hundreds of patients as we do per year, we are really treating a wide, heterogeneous group of patients. What we're trying to do with MIGS is trying to create a reproducible outcome in what is very much a heterogeneous group of patients with groups of pathologies. And I think Elios does take a big step forward in creating that sort of more homogeneous effect, which, every surgeon looks for. We have so much choice in the MIG space at the moment. What impact has Elios had in terms of your practice, either the flow, satisfaction, outcomes? What is it that's made you think after 100 cases, I'm going to do my second 100 and my third 100? What is it about Elios?
Well, I can tell you the impact was quite high. In fact, we're still sitting on the handpieces of a competitor, close to 100, and my colleagues and I are reluctant to use them. And I don't want to mention that, but I've done a lot of those cases with this other device. The key difference really is patient satisfaction and the ability to rehabilitate vision very quickly, not having any hyphema or very, very minimal hyphema, especially in monocular patients, especially in myopic patients. Sometimes I think in myopic patients, this is almost like a suction pump. The movement of the iris lens diaphragm is so wild in our high axial length myopic eye patients that as soon as you're done with the case, it looks great. You take your instruments out, and then almost the movement of the iris and lens posterior seem to be sucking back quite a bit of venous blood from an unroofed Schlemm's canal. And then, of course, it trickles past the IOL, it trickles into the vitreous, and then you have this nice gift to appreciate that surgery for another weeks or months with a comprehensive ablation of meshwork. That never happens with, at least I haven't seen it a single time in these 300 ELTs we've done, or Elios procedures. So that caused us to really switch.
Jose, have you sort of looked either formally or informally at sort of quality of life or patient satisfaction with the sort of the cases that you've done?
Yes, I can. I have a nice example of a patient that had, he was very concerned about using drops, and he had cataracts. So I offered him to have an Elios procedure. And when, 3 months after the surgery, he came to the clinic for a regular checkup, and he said, "This is amazing. I've been using drops for years, and now it's like a relief. He felt free of using the drops again." And I think that for some patients, this is like getting rid of the disease for a while. They know they have glaucoma, but if they have to use the drops every single day, they are reminded that they have the disease every day by using the drops. If they can stop using the drops, it's like being free of the disease.
Yeah.
So they just remind that they have the disease when they have to come back to the follow-up visit. But apart from that, for them, is fantastic.
Yeah, it reduces that daily psychological reminder that they have a potentially blinding condition. Yeah, I think we really estimate the psychosocial impact that this diagnosis has on patients. And if you can take away that daily reminder, I think it definitely improves their quality of life, anxiety, depression, all of those sorts of scales. And in terms of talking about that daily reminder of eye drops, what do you do post-operatively after Elios? Do you stop the drops, continue the drops, reduce the drops?
So in general, I take off the drops after glaucoma surgery, and they just get some local steroids, and for some days antibiotics. Even we can discuss about the need of antibiotics, and then we follow up the patients, and if we are not satisfied concerning the level of IOP, we restart with the eye drops. And this is really independent, because we discussed a lot about that of that procedure. Because I do not perform Elios in end-stage glaucoma, for example. So that's why it's independent of the number of medications the patients have before surgery or whatever. I really do a dropout. I stop the medications, and then I see and wait what's going on, because I also can get the information about the efficacy of the IOP reduction,
Yeah, and I think that goes back to a question about what is the success or what is the outcome we're looking for with MIGS. I think trying to base that too much on IOP reduction compared to either medicated or, as Dan had alluded to, washed out IOP. I think we can get a bit too obsessed about the number that we're looking at post-operatively. Do you guys, sort of an open question to everyone, do you guys have an idea, either exact or ballpark, what percentage of your post-Elios patients are drop-free? Because that really is the holy grail if we can achieve that. Anyone got any sort of numbers?
I would say that maybe around 75% could be drop-free 1 year after the surgery.
Amazing.
Wow.
Niles, Dan, any?
My guess would be 50%, but I haven't actually analyzed our 1-year data that carefully yet.
So even I have no exact numbers, but we have a really huge reduction of medication in terms of numbers, so that's and I guess this is a really most important point, that, as you mentioned already, it's not only the question of IOP reduction, but it's really of importance to the reduction of medications, because this really improves the quality of life, and a lot of patients have a lot of sides. Every patient has a conjunctivitis and mammalian gland dysfunction, and that's why I guess in general mixed procedures should be mentioned very, very early in the course of glaucoma disease.
Thank you all for your wealth of experience that you've given so far. I'm going to have one final question. I'm going to very unfairly point it at Mr. Dan Lindfield. So we're talking about giving it a go. You've got a colleague that you're having a beer with, and they say, "Oh, Dan, I've been doing X procedure with this device or whatever MIGS, and I'm happy. I'm getting good pressures, and I've got comfortable with it." What would you tell them informally over a beer, not on a recorded podcast? Why should they have a go with Elios?
What would you say over a beer on a non-recorded podcast on a recorded podcast? Yeah, good question. I think everyone's got resistance to change. We've all got that, haven't we? We're all a bit stubborn, and when you find something you're happy with, you kind of just sit on your hands and think, okay. And there's the early adopters who find new technology exciting. There's the naysayers, and there's the kind of slow to adopt, but they'll get there. We need data. So without data, this is all opinion, world-class opinion, with some brilliant people on this podcast, but it is opinion, and we owe it to ourselves to try and prove where this technology belongs. But I would be confident in saying that it's easy to adopt, easy for patients, easy for surgeon. It's quick, and it's reproducibly or confident results. So I think there's no real reason not to try it, and just try and see. As you've heard, the learning curve is pretty short, but yeah, I've not looked back. But yeah, will there be more stuff to come? I'm sure there will be, but I think this is an exciting step and a really good one for the here and now.
Fantastic. Well, thank you guys. Nils, Jose, Anselm, Dan, thank you so much. So many cases under your belt, so much experience and pearls that you have shared with all our listeners today. So thank you very much for your time. I hope the listeners got a bit of a oversight into Elios if they didn't know so much about it before, and those that did, hopefully they've picked up some more teaching points. So thank you very much for your time, and stay tuned for the next episode.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision is a wholly owned subsidiary of Bausch & Lomb. Elios Vision GmbH is the EU distributor of Elios, manufactured by Emlays GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.